This is a case report of an opportunistic nocardia pauciverans infection manifesting as an intramuscular abscess within the hamstring musculature of an immunosuppressed 59-year-old man. This is unique because although there are greater than 500 nocardiosis cases each year in the US caused by any of 40 species of nocardia, there's only one other documented case of an intramuscular abscess caused by nocardia pauciverans. That case was in the iliopsoas muscle of an immunocompetent patient with dissemination throughout the brain and lungs. For most cases of nocardiosis, prognosis is relatively good, with cure rates of greater than 80% in localized or even disseminated disease in immunocompetent patients. Disseminated disease in immunocompromised patients, though, has a cure rate of less than 15%. This case features a 59-year-old man with a 53-pack-year smoking history and a high degree of immunosuppression following kidney transplantation 3 years prior. 4 months prior to presentation to us, he was hospitalized with squamous cell carcinoma of the vocal cords, received radiation therapy leading to laryngeal tissue necrosis, with a 31-day hospital stay for hyperbaric therapy, resulting in deep vein thrombosis and a saddle pulmonary embolism. CT for the PE revealed a nodule in the upper lobe of the right lung concerning for malignancy. PET scan then revealed a high uptake lesion in the right posterior chest wall and the left posterior thigh. The patient then presented to us in orthopedics with 4 months of progressive posterior left thigh pain. X-ray revealed no calcifications of the mass, and MRI revealed a large lesion with heterogeneous signal intensity within the proximal hamstring musculature. This was presumed to be a soft tissue tumor based upon clinical history and imaging characteristics, so an incisional biopsy was undertaken, which showed only edematous skeletal muscle and no concern for malignancy. 2 weeks later, cultures grew nocardia, and speciation revealed nocardia pauciverans through MALDI mass spectrometry. In the 2 weeks while awaiting culture results, the patient experienced rapidly progressive posterior thigh pain and increasing narcotic use, with a new CT revealing enlargement of the thigh abscess by 270%. Surgical incision and drainage released 300 cc's of brown purulent fluid and revealed intact hamstring musculature. The right posterior chest wall mass was also excised. Postoperatively, the patient was started on Bactrim and imipenem. Pathology again revealed no signs of malignancy, and cultures grew nocardia pauciverans from both sites. The patient was discharged on 6 weeks of Bactrim and ceftriaxone, followed by 12 months of Bactrim monotherapy. At 4 months post-op, both incisional sites were well healed. A PET scan revealed no residual hypermetabolic activity at either site. The initial lung nodule, never confirmed as nocardia, reduced from 6.7 to 4.5 millimeters on antibiotics. This report details a disseminated opportunistic nocardia infection presenting as a presumed soft tissue tumor. This is likely to become more common as rates of both immunosuppression and nocardiosis rise. Lesions that are hypermetabolic on PET scan are rightfully worked up as malignancies, especially when a patient has a history of cancer, but it's important to maintain a high index of suspicion for infectious etiologies as well. Delays in diagnosis and appropriate treatment can lead to higher rates of dissemination with markedly worsening prognosis.